Approaches in Autism. We will be following an informal debate format. Audrey will discuss the pros of early intervention and Rob will discuss the cons. Next, Alani will address the pros of autonomy and choice making, and Jacqueline will address the cons. Finally, Robin will present pros for treatment, planning, and implementation, and Sarah will close with the cons for that argument. Here is Audrey with early intervention.
Hi, I'm Audrey, and I'm going to talk about early intervention and its vital importance for children with autism. Children with autism are most impaired in the areas of social interaction and communication, and often have high rates of stereotyped and repetitive behaviors. Although these symptoms occur within a range of severity, they can often be quite severe and may interfere with learning. Early intervention, specifically ABA, is a powerful tool for reducing these symptoms of autism. So why is ABA so powerful, and why is it important to intervene early with children with autism? First of all, reducing symptoms may help children with autism realize their cognitive potential. In 2008, Itzchak, Lahat, Bergen, and Zaker performed Pearson correlation for the Autism Diagnosis Observation Schedule, or ADOS, and IQ scores of 44 children with autism. They found IQ scores were inversely related to the children's ADOS scores in language and communication, reciprocal social interaction, play, stereotype behavior, and restricted interests, which indicates that better cognitive ability is associated with less severe symptoms. Furthermore, they looked at the ability of early intervention to improve outcomes for the 44 autistic children versus those with other developmental disabilities such as cerebral palsy. At the outset of the study, the cognitive levels of the 44 with autism and 37 children in the DD group were at similar levels. After 1 year of intervention, a two-way MANOVA was performed over the IQ scores at pre and post intervention times for the two groups. This yielded a significant time effect, with IQ scores increasing from pre to post intervention time, and also a significant time group interaction. So I'll show a table from that study. So as you can see, the IQ scores for both the autism and the DD groups, they both increased, but the autism group increased more significantly than the developmental disability group. The autism group's IQ scores improved 14.82 points, which is significant compared to the DD group improvement of 8.76 points. The ADOS was also re-administered to the autism group, and it was found that IQ improvements correlated significantly with the reduction in stereotype behaviors and improvement in language and communication. What the dramatic increase in IQ scores in the autism group compared to the control group may indicate is that autism symptoms, such as lack of interest in cooperating or engaging with the examiner, rather than cognitive impairment, is actually the reason for the lower baseline scores. Therefore, symptoms of autism may be interfering with otherwise relatively normal learning, and reducing these symptoms may help children come closer to realizing their cognitive potential. Additionally, Eichseth, Smith, Jar, and Eldavik in 2016 examined the functioning and behavior problems of a group of autistic children who were treated with ABA compared to a group treated with an eclectic variety of treatments such as TEACH, sensory integration, some ABA, and other treatments. The follow-up study showed an increase of 25 points in IQ from 62 to 87 for the ABA group, compared to an increase of only 7 points, 65 to 72, for the eclectic treatment group. Mean scores on the Vineland Adaptive Behavior Scales increased 9 to 20 points for the ABA group. However, scores for the eclectic group actually decreased 6 to 12 points. The behavioral treatment group also gained an average of 12 points in adaptive functioning. as measured by the Vineland Adaptive Behavior Scales, 20 points in Vineland Communication, 9 points in Vineland Daily Living Skills, and 12 points in Vineland Socialization Skills. Furthermore, the eclectic treatment group obtained an average change of minus 10 points in Vineland adaptive functioning, minus 7 points in Vineland communication, minus 6 points in Vineland daily living skills, and minus 12 points on Vineland socialization. So as you can see, the cognitive skills of autistic children can improve with early intervention, but ABA also improves communication and behavior skills. ABA has a socially significant impact on families in the areas of communication, behavior, and quality of life. Researchers McPhillamy and Dillenberger surveyed 15 families in Europe where ABA services are not readily available. The parents in the study had provided in-home ABA for their children at great personal expense. All surveyed parents stated that ABA-based interventions had a positive impact on their children and families. The families expressed that frustration and problem behaviors were reduced due to improved communication, and that is not all. Here are just a few of the direct quotes parents provided in the survey. So some quotes are, they're more affectionate, can now communicate with family visitors at home, going from special education to mainstream education, being understood by outside people outside the family, having more tolerance and a longer attention span, reducing frustration, stopping self-harm, ability to play with siblings, understanding the consequences of behavior, and providing skills for parents when they are faced with problem behaviors. So as you can see, parents cited specific improvements and it increased the ability to learn and the understanding of consequences. All of the parents emphasized dramatic improvement in their family life. They cited reduced stress, more manageable family outings, and increased skill for the parents in handling problem behaviors in public and in general. So even with the cost associated with ABA, the families found that the improved quality of life for their children and themselves was worth it. In fact, Furman and Tuminello argue that these interventions are costly, but they are actually cost-effective in the long run. They point out that ABA helps increase a child's autonomy, and any way we can increase autonomy is more cost-effective in the long run because fewer services will be needed. As McPhillamy and Dillenberger point out, the economic cost of supporting those with ASD who do not receive early behavioral intervention are astronomical because they will often need lifelong care and services. They also remind us that ABA teaches independence and self-sufficiency, and the aim of an ABA intervention is to bring the person to the point where they have the skills and confidence to navigate the demands of a dynamically changing world. So here is Rob presenting the argument that early intervention may not actually be such a good idea.
Hello, I'm Rob Pettibone. I will be addressing the cons of early intervention as viewed by those within the neurodiversity movement. Neurodiversity is best summed up as giving those with autism spectrum disorder, or ASD, the same rights as a person considered typical. It seeks an enlightened view of ASD as part of the normal pattern of human development and state of being. To understand, we must untangle it from comorbid conditions such as intellectual disabilities. When we acknowledge that ASD is part of the vast experience of what it means to be human, some issues become evident. Our approach to ASD is rooted in the medical model. The medical model focuses on a cure for ASD. The emphasis of this cure, often ABA, seeks to address behaviors that are not seen as typical, often claiming that it enables the individual to function within typical society. Two flaws exist with the medical model. 1. There are no known vectors for ASD. Even after extensive research, no cause of ASD has been identified. While there are some loose correlations to genetic factors in brain development, no consensus on causal factors exists. 2. Science once believed certain forms of sexual behavior were abnormal. This was an example of science bending to cultural pressures. Science biased by preconceived notions of what was acceptable and what was not. Like ASD, no causal factors existed to support these behaviors being disordered. Science has now self-corrected and removed these sexual diagnoses from diagnostic and statistical manual. Neurodiversity asks that we step back from the medical model and broaden our understanding of what constitutes healthy living. Even the politically correct form of identification, a person with ASD, suggests that the individual is trapped behind ASD. Unlike a person with a depression, ASD is inseparable from the individual. Also, unlike depression, ASD is not simply an organic or chemical malfunction within the individual. Neurodiversity also asks that we re-examine what is functional. Jarsman and Wellen in 2012 advocate that functional or flourishing is an animal faring well. Faring well is identified as the factors contentment, self-worth, confidence, and personal achievement. ASD alone is not an impediment to an individual excelling in these factors. The case for neurodiversity is not without natural corollaries, and what counts as adaptive or maladaptive is context sensitive. As an example, cross-fostered chimps are raised by humans in a non-wild setting. These chimps are not seen as cognitively or neurologically abnormal or disordered. They are functional and flourishing within their context. However, these chimps lack fitness traits needed to successfully survive in the wild. Additionally, Eddy, Brewer, Bird, Cook, Johnson, and Press in 2016 conducted a study comparing the ability of typical and ASD individuals to ascertain mental states. Typical individuals were found to be less able to ascertain the mental states of individuals with ASD. However, individuals with ASD could ascertain the mental state of typical and ASD individuals at the same level. The typical individuals in this case were less capable of adapting in this context. The argument that ASD is maladaptive is simply one of context. Neurodiversity, like human rights movements, asks us to re-examine our perceptions of the world. The core ethical principle of applied behavior analysis is do no harm. In seeking to treat autism as a disorder or disease with symptoms in need of a cure, we are violating this principle. There is currently no scientific proof that autism is a disease. Neurodiversity also challenges the very notion that autism is a disorder. In addition, autism should be viewed as simply an expression of naturally conferred traits. Autism is another way of being human. The behaviors expressed in autism are neither harmful to the person or society. Treating someone because they are not typical is harmful. This harming is especially troubling when somebody has a comorbid condition such as intellectual disabilities or when they are a minor whose desires may not be acknowledged. Neurodiversity challenges the very notion that early intervention is necessary and that the treatment may in fact be harmful. Next, Eleni will be discussing autonomy and choice making.
Hello, my name is Eleni, and I'm going to be talking about autonomy and choice making regarding the pro side. According to Loden, ABA intervention helps people with developmental and intellectual disabilities realize their cognitive potential. Therefore, it promotes autonomy. People must be able to understand and obtain information about choices they wish to make. The ability to reason and to act in a meaningful way, the capacity to value, the presence of preferences, and the absence of manipulation are considered vital for autonomy to exist. In this concept, it is assumed that to exercise personal autonomy, people must have the information that is needed in order to make informed choices. In fact, the elements of mental capacity and having enough information on which to base choices have been recognized by law as requirements when evaluating the quality of consent of all people, including those with developmental and intellectual disabilities. It is argued that many people with disabilities need assistance before they're able to exercise their autonomy, and that often means that we must create the right conditions for them. For people with disabilities, these include, whenever possible, helping them to recognize and organize their values, their sense of identity, assist them with reasoning and communication, encourage them to think outside the box, and foster mutual relationships. Research has shown that kids with autism may never learn to reach their highest potential if ABA intervention is not used with them. Research has also shown that kids with ASD that have been treated with ABA procedures have developed very similarly to normally developing children. Another argument follows that right conditions have to exist for individuals with disabilities to make the right choice. Not only has legislation mandated habilitation, but most laws make funding contingent on compliance with specific habilitative standards that emphasize the teaching of independent living skills, as well as the provision of a safe and attractive living environment for all individuals. Understanding and volunteerness should be assessed on a decision-specific basis. The strongest argument against the right to choose is that many people with developmental disabilities may make bad choices. Other clients with limited skills may choose a skill that they have not mastered. For instance, they might make an incomplete lunch or attempt to take the bus to work without knowing how to do that. Although other members of the society enjoy the right to choose an incomplete lunch or engage in other unproductive or even unsafe activities, they typically have enough learned skills and behaviors that make them aware of the consequences of their behaviors. The argument follows that people who do not have enough learned skills and who do not understand the consequences of their behaviors require intensive teaching in these areas before being allowed to choose. Until they're ready to make choices with understanding of the consequences, it is in their best interest for a teacher, an advocate, or a guardian to assist them. Another argument follows that personal liberties in order to teach independent living skills for the rest of an individual's lifespan is actually an appropriate trade-off. This means that a client could possibly pick a leisure activity over a vocational activity, which could seriously compromise their chances to find a job later on in life. In fact, some people have no leisure activities and would engage in stereotypic behaviors, self-injury behaviors, or napping instead. Another argument against giving clients the right to choose is that allowing this freedom may compromise their acquisition of critical independent living skills. For example, if a client is allowed to choose to be dressed by a staff member each day, that client may never learn how to do that on their own. This violates the core principle of respecting autonomy. ABA professionals are trained to promote the client's independency. ABA principles are not designed to remove autonomy from clients with disability, but rather assist them with prompting, shaping, chaining, and fading procedures. For example, that's why society has chose to treat minors in a similar way. It is assumed that that until they're ready to make their own choices, someone who is responsible for them is going to make the choices for them, and that eventually in life they'll be able to make their own choices. Next, Jacqueline is going to be talking about the con side of autonomy and choice making.
Hello, I'm Jacqueline, and I'm going to be presenting the con side of autonomy and choice making. According to the Balancing the Right to Habilitation with the Right to Personal Liberties, the Rights of People with Development Disabilities to Eat Too Many Donuts and Take a Nap by Bannerman, Sheldon, Sherman, and Harchick, in the pursuit of efficient habilitation, many service providers exercise a great deal of control over the lives of clients with developmental disabilities. Service providers often choose the client's habilitative goals, choose their work or day treatment setting, impose inflexible daily activity schedules, and regulate access to preferred activities. The choices made by the service providers may indeed promote habilitation, but those choices may not reflect the client's preferences. With that in mind, we're going to talk about personal liberties, the right to choose and to refuse. Legally, personal liberties include freedom of speech, religion, and other constitutional rights. Bannerman, Sheldon, Sherman, and Harchick, however, argue that personal liberties are even more basic than those detailed in the Constitution. Supreme Court Justice William O. Douglas discussed the right to be let alone. including the privilege an individual has to plan his own affairs, to shape his own life as he thinks best, to do what he pleases, go where he pleases, freedom from bodily restraint or compulsion, freedom to walk, stroll, or to loaf. So, people enjoy partaking in unproductive but harmless activities that they like, including watching TV, eating junk food, hanging out with who they want, taking a shower when they want. These things, the question is whether clients are given the opportunity by their service providers to exercise these liberties that are cherished by most people, including those with developmental disabilities, which is a quote from Bannerman's article. Okay. Clients may have little say in the goals that are being set or teaching procedures used. Decisions regarding teaching leisure activities and methods or carrying out self-help skills may have more to do with the instructor's preferences and history of learning than the client's. So an example of this would be brushing your teeth. Do you prefer to put the toothpaste on first, or do you prefer to turn the faucet on first? Do you prefer to brush the top of your teeth or the bottom of your teeth first? These liberties and decisions are what Bannerman refers to as perceived choices, and they make our lives more our own. Okay, so support workers make substitute decisions and are guided by how they would make such decisions in their own lives, not necessarily based on the client's. Again, the client's preferences are ignored. Choice making in regard to personal freedoms and leisure activities is severely limited to the constructs of those supporting the individual. So what happens here is we're compromising liberties to achieve habilitation. Clients may have little or no input in decisions regarding their priority treatment goals or on the procedures used to teach them. Clients, therefore, are less likely to be motivated to meet these goals. Choice making is not often taught. The Bannerman article quotes Shevin and Klein, stating, "Our profession is focused on choice making as a permissible activity rather than a teaching target. Many people require teaching to help them discover their own preferences and learn to make responsible choices. So many people need to be taught how to discover their own preferences. And opportunities for choice making are not often given. Other agendas are at play." Bannerman states, "The pressure to meet regulatory standards may cause some service providers to put too much emphasis on the quantity and scheduling of habilitative activities, and flexible scheduling often precludes opportunities for choice. For instance, clients may not be allowed to choose the order or timing of activities. They may be discouraged from taking breaks or from choosing activities that are not scheduled. Staff may pick out clients' clothes. A dietitian may plan clients' meals. Leisure materials may be locked in a cabinet until scheduled leisure times." Here we must look at 2.02 of the Professional and Ethical Compliance Code for Behavior Analysis, which is responsibility. Are service providers truly looking out for the best interest of their clients? Are they just doing what's convenient and works best for them? This is what we need to be thinking of when we discuss autonomy and choice making and how this affects personal liberties. Next, we have Robin, who will be presenting the treatment, planning, and implementation.
Hello, my name is Robin. When we are considering the ethics of treatment planning and implementation, it's important to firstly define what treatment we are referring to as ABA actually is. When discussing effectiveness and ethics of ABA, we should be considering it as a science rather than as a collection of techniques or treatments for autism. We should be considering ABA that references the analytic dimension as outlined by Bayer, Wolf, and Riesling. One of the defining features of ABA is that it is analytic in nature, and ethical guidelines for behaviour analysts state that functional assessment should be used before implementing treatment plans. We've already heard that there is significant evidence that early and intensive behaviour interventions based on behaviour analysis results in noticeable and lasting functional improvements for children with autism. When it comes to early intervention, there are many techniques based on the principles of ABA, such as discrete trial training, PECS, verbal behaviour, and pivotal response training that can be used to teach new skills to children with autism. Dillenberger and Keenan point out that these are merely techniques, and that there is a difference between simply implementing treatment consisting of specific techniques compared to truly learning and understanding the science of ABA and providing treatment as a result of this depth of knowledge and understanding. Matchston and Kontz have identified treatment integrity as one of the most concerning and variable factors in early intervention programs. As with any intervention, it is unfair to try and assess the efficacy or worth of a treatment when it is not implemented with integrity and fidelity and following the guidelines of best practice. Therefore, when evaluating ABA and the client's right to effective treatment, we must ensure that treatment fidelity remains high and that the true science of ABA and not just a few of its techniques are being practiced. When we consider the rights that clients have to effective treatment and the mountain of research that proves the efficacy of ABA in teaching new skills through intensive early intervention, we can confidently say that when applied as intended, it is a way of teaching that takes the learning style of children with autism into account and in turn employs teaching techniques that can help these children learn to flourish. According to Hastings and Noon, when it comes to dealing with self-injurious behaviour, evidence suggests that treatment based on the results of functional assessment is likely to be more effective, less likely to be considered restrictive, more likely to be seen as socially valid, and also focuses on the principles of a constructional approach to behaviour change. Again, it is important to distinguish whether we are simply discussing behaviour modification, where treatment is based on reinforcement or punishment techniques, or to the science of ABA, which applies the analytic dimension of treatment, which is based on a hypothesis of the causes of the behaviour. When we consider the right to effective treatment for those people who are displaying self-injurious behaviour, there are consistent findings across meta-analytic reviews that functional assessment of these severe behavioural issues increases the effectiveness of treatment significantly. The social environment is arranged so that self-injury is not reinforced, but a functionally equivalent and socially appropriate behaviour is reinforced instead. Hastings and Noon also state that treatment based on functional assessment has and is more likely to be implemented with higher treatment fidelity. As mentioned earlier, another important ethical consideration when considering ABA as a treatment is the question, does it address the goal of application of least restrictive treatment alternatives? The answer is yes. Wherever possible, reinforcement procedures are used as a first choice. A functional assessment's goal is not just to simply reduce the behaviour, but more importantly, enable the client to learn new, more appropriate replacement behaviours. It is the learning of new socially acceptable behaviours that makes this treatment ethically preferable because of the likelihood of it being less restrictive. The focus is on learning new positive behaviours and therefore increasing the quality of life of the client. Hastings and Noon also touched on treatment based on functional assessments and the relationship to social validity. There is still need for more study, but early indications are that treatment using positive reinforcement is more likely to be judged as acceptable by its consumers. So in conclusion, it can be said that treatment that is based on the results of a prior functional assessment, that is treatment that is based on the science of ABA, can be claimed to be more ethically acceptable based on the arguments that it is more effective overall, more likely to generalise and maintain, more likely to be implemented with good fidelity by staff. And because this method involves the teaching of new skills, it is considered less restrictive and more likely to be viewed by consumers as acceptable. I'll now hand you over to Sarah, who is going to present the other side of the argument for treatment planning and implementation.
Hello, I'm Sarah, and I will be concluding the debate by discussing the cons for treatment planning and implementation in ABA. Though it is undeniable that applied behavior analysis has made great ethical improvement over the past few decades, especially in terms of research and earlier intervention, ethical dilemmas arise still today. Within the realm of autism, behavior analysts are increasingly in demand for situations that require cooperation and collaboration among a multitude of professionals, many of whom may not be familiar with ABA and its technology. In such situations, it is suggested that behavior analysts may not adequately take into account the laws and ethics legislation of other professional fields, even though it may directly pertain to their clients. A recent study in law research by Hilbram, Phillips, and Thornwell in 2016 shows that research in behavioral sciences rarely cite the ethical legislation and standards of relevant judicial fields, even though the adherence to which may directly pertain to their client's situation. The authors discuss a need for more comprehensive exposure of professional standards to policymakers, researchers, and practitioners in the behavioral sciences in order to uphold a better informed policy and more uniformed, high-quality practice. I will show results from this study. So this study calculated rates of citations in research literature for 4 sets of professional standards across behavioral science and legal databases. Results of the study show that within the behavioral sciences, the average citation count for ethical legislation outside of the directly related field was significantly lower than the citation count for the APA Ethical Principles of Psychologists and Code of Conduct. Authors of this article suggest that professionals in this field are not adequately trained in or simply do not take into account these governing constructs for professional conduct. This negligence of legislation from related fields may lead behavior analysts to unknowingly violate the Ethical Compliance Code 1.04 integrity, specifically sections D and E, referring to conforming with the laws and ethical codes of the community and resolving conflicts with such collaboration. Especially in the increasingly more common event of taking on a client by request of a government agency such as social services, court-ordered services, and the Department of Education, etc., awareness of ethical legislation and updated codes may be paramount for successful interprofessional collaboration. Beyond lacking awareness for all parties' ethical standards while cooperating with other professionals in the provision of an optimal quality environment for the client, considerable confusion amongst involved parties may arise when it comes to subjective interpretation of some particularly vague terms in the Ethical Compliance Code for behavior analysts concerning client inclusion in treatment planning and daily decision-making. For example, the broad applicability of the term client as described in Code 2.0 might create confusion when determining the ethicality of whom to include in the planning and decision-making processes, be it the service recipient, the parents or guardians, various family members, caretakers, teachers and school staff, other professionals providing services to the clients, etc. In fact, throughout the Compliance Code, for example, in Code 2.03, A, consultation, and in 2.09D, treatment and intervention integrity, there is frequent usage of the phrase, the best interest of their client. With such a loosely defined parameter for the client, interpretation of the best interest of such client is likely to vary considerably. The vagueness of these terms throughout the Ethical Compliance Code may be interpreted as deliberate measures of flexibility for the expected interaction with parties of various professions and backgrounds. However, as discussed in Chapter 3 of the Supervisor's Guidebook by Reed, Parsons, and Green in 2012, neglecting to clarify specific work responsibilities significantly lowers the likelihood of successful quality staff performance. In this sense, without specifically defining parameters or standards for defining the client and therefore the best interest of the client, it seems that inclusion of the direct recipient of services in the decision-making and treatment planning is often left to the discretion of the behavior analyst in charge of drafting the treatment plan. Compliance Code 4.0 may be addressed when analyzing parent perspectives and involvement in treatment planning and consent. In a 2014 study by Robert LeBlanc and Boyer, the degree to which parents were satisfied with ABA services negatively correlated with the desire for involvement in treatment planning. And I will show you a visual for this. The study used transversal and vertical analyses to interpret 15 parents' perspectives on received specialized support services and found two main areas from which satisfaction is constructed: whether parents see themselves as experts in regard to their child, and the parent's opinion of the purpose for the intervention or service. Interestingly, parents holding an overall satisfied outlook of the provided service tend to rely on the professional, such as behavior analyst, as expert of their child, assuming the professional knows how to better define best interests of the child than the parent does. The satisfied parent also tends to be concerned primarily with the present situation and the day-to-day care of their child. In contrast, parents holding an overall dissatisfied outlook of provided services tend to be more concerned with the big picture, how to enhance their child's development and consider themselves as experts of their child. In addition, dissatisfied parents tend to express desire for more involvement and input in the treatment planning process. Ethical compliance codes for behavior analysts that may be of particular interest when considering parent involvement in behavior change programs include the subsections of Code 4.0, especially 4.04, approving behavior change programs, 4.05, describing behavior change program objectives, and 4.07, environmental conditions that interfere with implementation. In considering the ethicality of constructing treatment plans in accordance with the ABA guidelines on the level of the impacted individual, it seems that the conceptual framework for assisting in the individual needs to address many often ignored controlling variables that potentially affect the client's ability to meaningfully participate in the decision-making process of his or her own treatment. According to Compliance Code 4.02, behavior analysts have the responsibility to tailor treatment plans to the unique conditions of the individual, and as described in Code 4.07, the behavior analyst must seek to eliminate environmental constraints obstructing the implementation of the behavior change program. A 2010 article by Lotus and L suggests many variables impacting the planning and decision-making process are commonly inadequately addressed in person-centered planning, such as the influencing factors of asymmetrical power and outer directedness, the context of autonomy, and implications of personality traits and motivational orientation. The authors insist that the professional community take awareness to these complex variables and provide a suggested guideline for including individuals in the decision-making process of their own treatment plan, which will now be displayed. This sample includes all important considerations present in many current decision-making tools, but goes further to emphasize attention to those unaddressed controlling variables discussed in the article. Upon awareness of these variables having an impact on clients' participation in decision-making, neglecting to provide an environment capable of enhancing such ability may be in violation of the previously mentioned compliance codes 4.03 and 4.07. In regard to the Ethical Compliance Code 1.01, reliance on scientific knowledge, the basis on which substitute decisions are made seems outdated. As a field of scientific rigor, we must not look only at ethics concerning the young ASD population involved in early intervention, but also keep in mind the ethical issues faced in ABA practices within the adult ASD population. As cited in a 2010 article by Dune, Clare, and Holland concerning individuals declared by the court as unfit to make their own choices, the majority of U.S. state legislation gives substitute decision-making rights to the next of kin to make hypothetical decisions based on the subjective opinion of what the next of kin thinks the client would decide. Whereas in the UK, the passing of the Mental Capacity Act in 2005 mandates an evidence-based best interest checklist to be used by substitute decision makers, which still involves subjective measures, but also requires objective measures for determining the client's best interest. Another ethical dilemma concerning those deemed unable to act within their own best interest is within support staff's adherence to ethical codes and regulations in the context of making day-to-day substitute decisions and implementing treatment plans. In many cases, direct care providers do not understand the purpose of or agree with behavioral plan procedures and may deviate from the written plan. In the qualitative study conducted by Dune, Clare, and Holland, support staff admitted to ignoring intervention implementation procedures or the facility's policies in each of three unassociated residential facilities for adults with intellectual disabilities and developmental disabilities. Support workers in the residential care settings were interviewed and directly observed in everyday care practices. Results from the study concluded that much of the support staff viewed resident life at the home as narrow and repetitive. Furthermore, staff were inclined to look at their own lives, routines, and values when making substitute decisions, even when these opinions conflicted with the resident's care plan. They feel that the care plans designed for patients severely limit opportunities and do not lead to fulfillment of clients' interests, which lead these workers to deviate from care plans. So often these workers are attempting to accommodate the lives of their clients by projecting their own values and perspectives into their work as direct care providers. They may inadvertently violate Ethical Compliance Code 2.09, Treatment and Intervention Efficacy. The study also found that direct care staff see value in allowing clients to take part in risk-taking behaviors, and some admit to violating agency rules to allow such behavior, as seen in the interview excerpt provided. Right here. Oops. Although the Ethical Compliance Code 4.0 behavior analysts in the Individual Behavior Change Program is worded to ensure that behavior analysts are responsible for all aspects of the treatment, including making sure that all staff and caregivers adhere to the implementation procedures, this standard seems to be largely ineffective as these situations continue to occur frequently. To account for this often overlooked phenomenon, the author suggests that support staff are not given enough training in the laws and governing ethics surrounding our field and may unknowingly commit ethical violations. They postulate that formal trainings of the legislation involved in ABA are typically reserved for managers and not direct care staff themselves. In congruence with this theory, the article on decision-making in adults with developmental disabilities by Lotus and Ells in 2010 states that the training of direct care providers is often left to the discretion of the company or agency, and there may be a lack of adequate training in ethical standards and legislation. In quickly revisiting Chapter 3 from the Supervisor's Guidebook by Reed Parsons and Green from 2012, I highlight the discussion of the supervisor's job in promoting effective work behavior involving a responsibility to ensure staff know specifically what to do and how to do it, along with a sense of why it is necessary, and also specifically what not to do. In providing specific performance responsibilities for direct care staff, the supervisor not only increases the likelihood of quality staff performance, he or she meets compliance to the previously addressed Ethical Code 4.0. In analyzing these ethical issues common to ABA treatment, there seems to exist a need for more universal and empirical regulations for defining client and consumer involvement in treatment planning and in training direct care staff in the ethics of treatments in ABA. Thank you for watching our debate on the ethicality of treatments in ABA.